So we're going to spend the next few minutes talking about Chapter 19, gastrointestinal and urologic emergencies. It's not a lot we can do about abdominal emergencies as a general rule, but we do want to be able to do a good assessment and treat them, recognize the life-threatening complications that can arise and treat appropriately. So we basically want to talk about that basic emergency care for acute abdomen, and talk about the anatomy of the abdomen, how different conditions present, how to manage shock associated with those particular emergencies, and we'll talk about gastrointestinal bleeding as well. We'll also discuss a little bit of the physiology behind acute and chronic GI hemorrhage, conditions like peritonitis, and all our ulcerative diseases as well. We're going to talk about our renal system. We'll talk a little bit about dialysis and the management of patients with kidney stones. So we'll get into it now. Abdominal pain is a very common complaint. You will never need to determine the exact cause. However, narrowing it down should be within your assessment ability. You should be able to recognize life-threatening conditions as well and make sure that you're able to act appropriately on those. So the abdominal cavity contains our gastrointestinal system. It also contains our genital system and our urinary system. It's made up of hollow and solid organs. Hollow organ is an organ that obviously is hollow, doesn't have anything inside, like stomachs and bladders, whereas solid organs, more like kidneys and spleens, are very vast. They're solid, they're very vascular. They can actually be lacerated and cause major hemorrhage and internal bleeding. When we breach a hollow organ, we'll see that whatever its contents are, whether it be bile or fecal matter or whatever, can leak into the surrounding cavity and cause a lot of irritation and infection and possible long-term issues. So here are illustrations of our abdominal cavity and the organs therein. Please note that we divide into the upper right and upper left, lower right and lower left quadrants. And anytime a patient is experiencing abdominal pain, just like any other pain, we want to make sure that we put hands on and actually palpate it. So solid organs are going to be our liver, our spleen, our pancreas, the kidneys, ovaries in women. Hollow organs include our gallbladder, stomach, our intestines, and our urinary bladder. So we'll talk a little bit about the GI system. We know that this is our gastrointestinal system is responsible for digestion of our food. It begins when our food is actually being chewed, starts being ground up and mixed with saliva. And the stomach is the main digestive organ. And those gastric juices break food down into components that can be absorbed into our intestinal tract and then into our bloodstream. The liver assists in digestion by excreting bile, and it helps in digesting fats. It also filters toxic substances produced by digestion, filtering the blood, and it creates glucose stores. Those glucose stores, you might hear advanced level providers talking about administering a drug called glucagon. That glucagon, that's what it does, is it acts on the liver to help release those sugar stores that are built up. And the gallbladder is just simply a reservoir for bile. It seems like a simple organ, but it sure can cause a lot of problems in a lot of people. Small intestine is made up of several parts. You have your duodenum, where digestive juices from pancreas and the liver mix with food. You have the jejunum, which actually absorbs your digestive product, and it does actually most of the work. And then we have the ileum, which also absorbs nutrients that were not absorbed earlier, and it absorbs those bile acids so they can be returned to the liver and used again. It also has vitamin B component for helping to make nerve cells and red blood cells. We have the colon, or the large intestine. That's where all the food that's not broken down comes there, and water is absorbed out of it, and stool is formed, ready to be passed out through our rectum. The spleen is in the mix because it is connected to the stomach and the liver through vessels, but it doesn't have any digestive function. So it's not technically a digestive organ. It's just located in the interconnective tissue of the digestive tract. So we talk about the genital system. Our male reproductive system is made up of everything from testicles all the way down to the penis. We have the prostate gland. We have a lot of people who have prostate issues, seminal vesicles where seminal fluid is stored. In the female reproductive system, we have the ovaries and the fallopian tubes. We have the uterus where excuse me, I apologize. We have the uterus where a fetus is born. We have, or I'm sorry, develops. We have the cervix, which is the opening between the uterus and the vagina is actually during childbirth known as the birthing canal. These are all our components. Our urinary system controls the discharge of waste material that's filtered from the blood by the kidneys. The kidneys are solid organs, and there are two of them. They're located in the retroperitoneal cavity, or that back cavity, back side of our abdominal cavity. There's one on each side of our body. Ureters, or those tubes, join each kidney to the urinary bladder, and the bladder is located behind the pubic symphysis, or the pubic bone. The bladder empties urine outside through the urethra, and we typically go through about 1.5 to 2 liters of urine per day. There's a diagram of our urinary system. We have the kidney here, the ureter, our urinary bladder. The prostate gland that we talked about in the male reproductive system, the external urethral opening of the urethra that travels to the penis for evacuation of urine. So we'll talk a little bit about pathophysiology of the abdominal cavity. There's a lot of big words in here, but a few of them I really want you to remember. Please remember peritoneum, okay? Peritoneum is the lining of the abdominal cavity, and there's actually two different kinds. There's the parietal peritoneum, which actually lines the exterior walls of the abdominal cavity, and the visceral peritoneum, which is that layer that covers all the organs. And foreign material, such as blood or bile or whatever, can actually irritate the peritoneum, and you could have a condition called peritonitis. And peritonitis on the end of any word simply means inflammation of, so that would be inflammation of the peritoneum. Acute abdomen is the term we will use to refer to the sudden onset of abdominal pain. It can be associated with lots of different problems requiring medical attention, but it's a blanket statement. We have acute abdomen, patient has acute abdominal pain, and we're transporting for such, and we're unable to determine specifically what is causing that pain. We just talked about peritonitis as being the inflammation of the peritoneum, and then we have the ileus, which can be cause paralysis of muscular contractions, and it can also the retained gas and feces can cause abdominal distension. It can make your stomach empty by emesis, vomiting. We have diverticulitis as a condition where small pockets at weak areas in the muscle walls of the abdomen can become inflamed. They can become impacted with different foreign materials. Cholecystitis is inflammation of the gallbladder. So you'll hear people say big words like patient had a cholecystectomy, but that simply means they had their gallbladder removed. And acute appendicitis, we know that a couple of the questions that we're going to be asking in our assessments are, do you still have your gallbladder, and do you still have your appendix? So the peritoneum, those layers are actually supplied by two different nerve systems. So the parietal, or that layer that it coats the interior wall of the abdomen, is supplied by the same nerves that connect the skin. So we can lay our hand, we touch on a surface, we feel it. We touch our skin, we feel our skin being touched or whatever. That same nerve set. Those somatic nerves are connected to the parietal peritoneum. However, the visceral peritoneum is supplied by the autonomic nervous system. So you might have difference in pain or referred pain, which means that one thing is happening, but we're feeling it somewhere else. That's why it's one of the reasons it's very difficult to dial in specific abdominal pain. Ulcers are caused by that protective layer of mucus in our gastrointestinal tract eroding, and acids allowed to eat into an organ. It could lead to peritonitis, or could just lead to bleeding in our GI tract. Gallstones, we've all heard of people having gallstones. These are formed by anything from overcalcification to, well, there's a long list of things that can actually cause gallstones, but they do cause pain. They can cause digestive problems. Sudden onset of an inflamed gallbladder or irritated gallbladder is very, very painful to our patient. We know our gallbladder is located in our upper right quadrant. But that pain may actually refer somewhere else. It may appear, our patient may be complaining of chest pain, or it may be traveling around to the back when it's actually the gallbladder that's inflamed. But those gallstones basically block the opening to the gallbladder, and so the bile is not allowed to exit for digestion, and basically just sits in one place and becomes stagnant. Pancreatitis is a popular one out there. It can come from anything from a gallstone to alcohol abuse. A lot of the signs that are associated with it would be vomiting. You might see some abdominal distension. Some of the symptoms might be complaining of pain in the upper quadrants or nausea. If it progresses, sepsis can occur, or even internal hemorrhage. A lot of these patients are on restrictive diets. They don't eat a lot of high-fat foods. They're not supposed to consume a lot of alcohol, but when they do slip and have a fatty food or drink or whatever, it can actually cause an exacerbation of their pancreatitis and then sudden onset of abdominal pain. Appendicitis may be referred pain as well, but that is inflammation of the appendix. You might see long-term effects of anorexia or nausea and vomiting. Could be fever and chills, flu-like symptoms. Might have some rebound tenderness. And what rebound tenderness is, remember that in our patient assessment, when we assess the abdomen, and anytime anything hurts, we palpate it. When we get down to our lower right quadrant, remember we ask, does it hurt when I push in? Does it hurt when I let go? If it hurts when I let go and not when I push in, that is called rebound tenderness, and that is a symptom that's often associated with appendicitis. Gastrointestinal hemorrhage is basically bleeding in our GI tract. Could be upper GI, lower GI, might be something acute, or this could be an ongoing problem. You'll see they could be complaining of vomiting with blood in it. They could be complaining of having blood in their stool, or and that blood could be dark coffee ground, indicating an older bleed, or bright red, indicating an ongoing bleed. Esophagitis occurs when the lining of the esophagus becomes inflamed or gets eroded by acids through constant heartburn. You might have, or a constant, I should say, reflux. It could develop into symptoms like it hurts when they actually swallow. It could make them vomit because of that regurgitation of bile. They can have heartburn or actually sores in the mouth. Esophageal varices is one we don't see a whole lot, but it's associated with the capillary network in the esophagus. And that capillary network, there's small vessels are leaking, and if it ruptures, it can be an absolute life-threatening emergency. But long-term varices patients can have fatigue and weight loss, might have some liver or lead to liver failure with the jaundice there, the yellowing of the skin, the eyes. Anorexia could be swelling in different places, or generalized abdominal pain. Mallory-Weiss syndrome is actually when the junction between the stomach and the esophagus tears. And the biggest symptom you're going to see is going to be vomiting. But this can actually be caused by violent coughing or actually violent vomiting. And there's gastroenteritis. This is an infection, could be bacterial or viral, or it could be caused by non-infectious conditions. And this is basically, we're going to you're gonna have signs and symptoms of diarrhea. Could be have blood or pus in that stool, abdominal cramping, nausea, vomiting. That principal symptom is going to be diarrhea. And the biggest complication we're going to look for is possible dehydration from ongoing diarrhea, as the fluid output in the in the watery stool may be greater than the fluid intake of our patient. Lack of fiber in our diet can, a lack of fiber in our diet can cause consistency of stools to become more solid, requiring more work by the intestinal tract and abdominal walls. So fecal matter can become caught in the walls of the colon, and once they get caught in there and they're not evacuated, they can cause irritation and inflammation and move on to infection. We might see some conditions like or symptoms like fever, signs like fever, and symptoms like body aches and chills. Hemorrhoids are also a concern for hemorrhage, in that the hemorrhoids are created by swelling and inflammation of blood vessels that are surrounding the rectum. Those can be internal or they can protrude externally. During having bowel movements, there might be bright red blood present, and one would notice a question you might want to ask is, did it appear to be global, or did it appear to be potentially on one side of a stool? Because if that, as the stool passes through the rectum, if there's bleeding on one side, you might see actual blood down one side of the stool and not on the other. That's a good indicator that the hemorrhage is coming from hemorrhoids. Cystitis, or commonly referred to as a UTI or urinary tract infection, is a bacterial infection. If not treated, it can progress and cause a lot of issues. A much more serious infection is when it spreads to the kidneys, and we can if not addressed, it can cause kidney failure and can lead to sepsis. The kidneys, we know, play a major role in maintaining homeostasis, or acid-base balance in our body. When a kidney fails, then that uric acid is not filtered out of the body, so we become more acidic, and kidney stones can grow over time. I'm sure everyone knows someone that's had a kidney stone. They can form for many reasons. Some people have them once or twice in their life. Other people have chronic kidney stones, and they can create blockage and impede the kidneys from doing their job of filtering those waste products out of blood. Acute kidney failure is usually reversible with prompt diagnosis and treatment. They might go in, and it might be anything from a large number of kidney stones that need to be surgically removed, but chronic kidney failure is irreversible. It can develop as quickly as over a few months, but it usually takes years. Eventually, they're going to end up on dialysis, and as it progresses, there's a possibility that they may end up having to be on a transplant list. These patients that are on dialysis do have an increased risk of heart failure and cardiac arrest, because if they miss a dialysis treatment, then their body is going to retain that fluid, and that fluid's got to go somewhere. May end up having pulmonary edema, things like that. For our female population or female patient population, we need to make sure that we ask questions regarding the female reproductive organs. Make sure that you do this in a professional capacity, but these are things that we need to know. We need to know things regarding pregnancy, or potential for pregnancy, where the patient's sexually active, whatnot. But pain in the lower quadrants can be anything from ovarian cysts to ectopic pregnancies that are found in the fallopian tubes. We'll cover most of this in our gyno emergencies in I think it's chapter 23. So other organ systems that are in there, our vascular system is obviously located throughout our body, but the aorta, the largest artery in our body, comes from the top of the heart, down behind the heart, travels all the way down through the thoracic cavity and through the abdominal cavity. An abdominal aortic aneurysm, or a AAA, is just like any other aneurysm. If you remember from other lectures when we talked about a weakening portion of the blood vessel and it ballooning out, And if this were to happen, we have to use extreme caution, because if we feel a pulsating mass when we're palpating the abdomen or whatnot, sudden movements or patient stress could cause it to rupture. And this is the largest artery in the body that is we're talking about here. So massive hemorrhage can cause our patient to go into hypovolemic shock immediately. Hernias are just basically a protrusion of an organ or tissue through an opening in a body cavity where it's not supposed to be. You see people with abdominal wall hernias. Males have hernias in the groin sometimes and it may not always be noticeable. It may be an issue where that organ protrudes while you're standing, but when you lay down, it retreats back into its normal cavity. But we start having problems when and it doesn't always produce any noticeable mass or lump. However, if a portion of an organ or a tissue does pass through a cavity wall and becomes stuck there where it's unable to return to its normal position, we might get what's known as strangulation. And strangulation is a serious medical emergency. It causes an excessive amount of pain, but the blood flow to that portion that's protruding has been cut off, and so that tissue is literally not getting the oxygen and nutrients it needs, and so therefore can die, and tissue necrosis can set in internally. Serious signs of a hernia are going to be that protrusion that when you lay down it no longer recedes, pain at that site, maybe even tenderness when it's palpated, or red or bluish skin discoloration around the area of the hernia. So we know we've already talked about our scene safety on every PowerPoint so far, and our scene size up with our scene safety and standard precautions, MOI versus NOI. Remember that if there's abdominal pain, that it could be an act of violence. Someone may have been struck, but we're going to use our tools to assess for any life threats that may be present. We're going to do that, check that airway and breathing. Want to know, is the airway patent and maintainable? Want to know rate, rhythm, and quality of breathing. Want to be check circulation by feeling for a pulse, skin, looking for signs of hemorrhage. We're going to ask about blood or in vomit or stool, or if there have been black tarry stools, which leads us to believe that there may be older blood. We'd also make sure we check pulses in both feet to determine that there was no arterial involvement in the abdomen, and that those pulses were equal. And then we make our transport decision, and if there are signs of significant illness or emergency, obviously we're going to transport right away. Taking a sample history, we know all about sample history, signs, symptoms, allergies, medications, past medical history, last oral intake, and events leading to. But we also want to ask some other things about the specific condition. We want to ask, do you still have your gallbladder? Do you still have your appendix? We want to know things like, have you been urinating more frequently or less frequently? Has there been any burning sensation associated with it? Any possibility, have you seen any blood in your urine? Has there been an unusual odor? When was your last bowel movement? Was it normal? Was it, have you been constipated, or did you have a loose stool? Have you been having bowel movements more frequently? Were there black tarry stools, or the possibility of any bright red blood there or whatnot? We want to ask about vomiting and once again, belching, flatulence. Have you noticed any weight loss recently? Have you had any other signs and symptoms of pain that go along with it? Does your pain travel anywhere with that OPQRST? Is it coming around from the back? Do you have a history of kidney stones? Female specific questions we might ask. Is there any possibility that you're pregnant? Are you sexually active? Have you noticed any vaginal discharge? Have you noticed any unusual odors? When was your last menstrual cycle? Was it normal? Was it heavier or lighter? And those type of things. So there's a big list of questions that we can ask regarding abdominal pain in order to help us determine the cause and hopefully tailor our treatment a little bit. Palpation of the abdomen. We know that if anyone's complaining of abdominal pain that is specific, we want to start as far away from it as possible. Okay. Normal abdomen is soft and it's not tender, but if there is pain, that could be signs of acute abdomen. We're going to expose the abdomen to assess it, not press over the outside of clothing, because we want to see we're looking for discoloration and things as well. We place one hand on the other over the other, and we palpate gently, pushing in, making sure that our patient knows we want to know if it hurts when we press in, and it also if it hurts when we release. Once again, that's rebound tenderness. We're going to check our vital signs, check our respiratory rate, pulse rate. Anybody who's had kidney failure and goes to dialysis might have a fistula. I know when you're doing your checkoffs for vital signs, it says look for fistulas. Make sure that we try to avoid taking a blood pressure in the same arm where that fistula or dialysis shunt is located. And we want to reassess quite often. Make sure any interventions we've done treating for shock or given emotional support, we look to see how are they doing? Is our patient feel better? They're still in pain, but maybe they're a little more positive, or is our pain level going down? Is our pain changing? Is it going up? Do we see our patient guarding more and whatnot? And we can't really treat the causes of acute abdomen. Basically, what we can do is we can treat for shock when obvious signs, even when obvious signs aren't apparent. We can lay our patient down, make sure we keep them warm, but let them get in their position of comfort. Anything that helps alleviate their pain. We're not typically going to give ibuprofen and Tylenol for abdominal pain, simply because it's most likely not going to help. And if it were to reduce the pain, once we get to the facility, we don't want to mask that pain. We want the facility to be able to evaluate appropriately. And our review questions are up next, and this will be the end of our narrated portion of our PowerPoint.